Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is cerebrovascular accidents. So in this session, I will just be giving you a brief introduction to the topic. In the subsequent sessions on the topic of cerebrovascular accidents, I will be discussing this topic in detail. So first of all, you need to know what exactly you mean by the word stroke. Stroke, it is defined as sudden onset neurological deficit. Right, it is defined as sudden onset neurological deficit. And this particular neurological deficit, it is secondary to vascular involvement. Okay, so it is a sudden onset neurological deficit of a vascular basis. Right, of a vascular basis, and this particular neurological deficit will be lasting longer than 24 hours. Right, this particular neurological deficit will be lasting longer than 24 hours. That is what is your stroke. Then we have another important terminology that we need to know is TIA, that is transient ischemic attack. Transient ischemic attack, it is a sudden onset neurological deficit of a vascular basis, but so here also you have sudden onset neurological deficit. But this particular sudden onset neurological deficit, this is also, it is of vascular basis, but this particular neurological deficit will resolve within 24 hours. Right, so this particular neurological deficit will resolve within 24 hours, whereas stroke, the duration of neurological deficit will be for more than 24 hours. But whereas transient ischemic attack, here the neurological deficit will resolve within a brief period of 24 hours. That is what is called as the transient ischemic attack. And we have another terminology called as RIND, that is reversible ischemic neurological deficit. So here you will have sudden onset neurological deficit of vascular basis, right, sudden onset neurological deficit of vascular basis, and here the neurological deficit will be there for 24 to 72 hours. Right, here the neurological deficit will be there for more than 24 hours, and that will resolve completely or near completely within 72 hours. Right, that is what is your RIND, that is reversible ischemic neurological deficit. Now you take this transient ischemic attack, you need to know what is the risk of stroke following transient ischemic attack. Transient ischemic attack, what did I tell you? The neurological deficit will resolve within 24 hours. But whereas stroke, the duration of the neurological deficit will be there for more than 24 hours. So repeated TIA will progress to the development of stroke. Now, which group of individuals with TIA will develop stroke is given by a scoring system called as ABCD2 scoring system. So if you see here, A stands for age of the individuals. Age more than 60 years, score is 1. And if you take the blood pressure, if the systolic blood pressure is more than 140 and diastolic blood pressure is more than 90 millimeters of mercury, right, score given is 1. And coming on to the clinical symptoms, if the individual is having unilateral weakness, the score, right, the score which is given is 2. And if the individual has speech disturbances without weakness, then the score given is 1. If there is weakness, right, if there is unilateral weakness, the score given is 2. If there is speech disturbance without weakness, the score given is 1. Then coming on to the duration of transient ischemic attack. If the duration of transient ischemic attack is like if it is more than 60 minutes, the score given is 2. And if the duration of transient ischemic attack, if it is in between 10 to 59 minutes, then the score given is 1. And if the individual is diabetic, right, if the individual is diabetic, the score given is 1. So how much will be the total score? The total score, it will be around 7, right? So don't be under the impression that 1 plus 1, 2 plus 2 is 4, 5, 6, 7, 8, 9. So the score should be 9. You might be under that impression, but you have to understand and you have to know that is, if the duration is more than 60 minutes, we take only score 2. We don't take this particular score 1. Right? We don't take this particular score 1. And if the individual is having speech disturbance without weakness, then what we take is only this score 1 we will take. We don't take this score 2 at all. So in that way, the total score, it becomes around 7. So now what you need to know is, more is your ABCD2 score, higher is the chance of development of stroke. That is what is the importance of the ABCD2 scoring system. Now, if you take this cerebrovascular accidents, what are the etiologies which will cause cerebrovascular accidents? So it should be vascular basis. So you see this question. Most common cause of cerebrovascular accident is embolism, arterial thrombosis, venous thrombosis, hemorrhage. So if you take the etiology of the stroke, we classify the etiology of the stroke into two types. One, we have ischemic stroke, and second we have is the hemorrhagic stroke. Right, ischemic stroke and as well as the hemorrhagic stroke. Ischemic stroke, it constitutes 85%. Hemorrhagic stroke, it constitutes 15%. And out of this, you take the ischemic stroke. What are the causes for the ischemic stroke? Ischemic stroke, the etiology will be either it would be secondary to embolism or secondary to thrombosis. Right, secondary to embolism or thrombosis. So thrombosis, it constitutes 25% of ischemic strokes. Embolism, it constitutes 75% of the ischemic stroke. And if you take the hemorrhagic stroke, it is constituting only 15%. And where all the hemorrhage, the site of the hemorrhages, it could be intraparenchymal, number 2, it could be in the subarachnoid area, that is subarachnoid hemorrhage. It could be in the subdural area, that is subdural hemorrhage. And it could be extradural, that is extradural hemorrhage. So these are the causes for the hemorrhagic stroke: intraparenchymal, subarachnoid, subdural, extradural. So these are the etiologies that will cause the stroke, ischemic stroke and as well as the hemorrhagic stroke. Now, if you take the clinical presentation of this thrombotic stroke and as well as the embolic stroke. Thrombotic stroke, let me tell you, the individual will have gradual onset of neurological deficit. right? The individual will have gradual onset neurological deficit, gradual onset neurological deficit, and that means there will be a stepwise deficits that will occur. And in case of this particular thrombotic stroke, these patients, they have a past history of transient ischemic attacks, so preceded by transient ischemic attacks. That is what is your thrombotic stroke or thrombosis. You take this embolic stroke. Embolic stroke, the onset of this particular neurological deficit is abrupt in onset. Okay, so abrupt in onset of the neurological deficit will be there in case of the embolic stroke. And here there is no warning sign. Right, here there is no warning sign. That means there is no TIA. Right, there is no transient ischemic attack. The neurological deficit, whatever is there, right, the neurological deficit, whatever is there, it is maximal at the onset. Right, it is maximal at the onset. And in these individuals, the most common source of the emboli, it is cardiac origin. Right, the most common source of emboli, it is cardiac origin. And these patients, they are more prone to develop the seizures as well. That is what is called as the embolic stroke. Right, so this will be the clinical presentation of the ischemic stroke. If it is a thrombotic stroke, the neurological deficit will be of gradual in onset, stepwise deficit will be there. Whereas in embolic stroke, the neurological deficit will be abrupt in onset without any prior warning sign. That means there is no prior transient ischemic attack at all. Now, coming on to conditions associated with increased risk of cerebral ischemia. So we have vascular disorders which will cause the cerebral ischemia. That includes atherosclerosis, number 2, it can cause vasculitis is another important etiology for the development of the cerebral ischemia. Then systemic lupus erythematosus. Then syphilis is another important etiology. Then HIV AIDS is another important etiology. Then carotid or vertebral dissection. Right, carotid or vertebral dissection can also cause the development of the cerebral ischemia. And even certain drug abuse, certain drugs can induce the vascular disorders causing cerebral ischemia. And these particular drugs include cocaine. So the drugs include cocaine, then followed by that we have amphetamines, and the other drug which will cause the cerebral ischemia is the heroin. So these are the drugs which can cause or which has the risk of development of the cerebral ischemia. Then followed by that, in patients with chronic hypertension, they also develop lacunar infarcts. Right? So these are the vascular disorders which has the increased risk of development of cerebral ischemia. You take the cardiac disorders. Even cardiac disorders, they can cause the cerebral ischemia. How? By showering an emboli into the cerebral circulation. So, presence of mural thrombus, that is, presence of thrombus within the cardiac chambers which can split and enters into the circulation in the form of emboli, and they can enter into the cerebral circulation. Then patients with rheumatic heart disease, then patients with endocarditis, followed by that patients with mitral valve prolapse and prosthetic heart valves. So these are the cardiac disorders which will cause which has the increased risk of the cerebral ischemia. Then followed by that we have the hematological disorders which will cause the cerebrovascular accidents. And these hematological disorders, they include thrombocytosis, followed by that polycythemia, followed by that sickle cell disease, then next we have leukocytosis, then lastly we have hypercoagulable states. Right, so these are the hematological disorders which will cause the cerebrovascular accidents. Now we have vascular disorders, then we have cardiac disorders, then hematological disorders which will cause the cerebral ischemia. Then you take the etiology of the hemorrhagic stroke. Now it all depends upon where exactly is the site of hemorrhage. Like for example, you take in case of intracerebral hemorrhage, which is also called intraparenchymal hemorrhage. So in patients with intracerebral hemorrhage, the etiology for hemorrhagic stroke will be hypertension and amyloid angiopathy. Right, so these are the causes for intracerebral hemorrhage. Then followed by that, you need to know what are the etiologies causing subarachnoid hemorrhage. The etiologies causing subarachnoid hemorrhage include rupture of berry aneurysm, and then followed by that arteriovenous malformations. So these are the causes for the subarachnoid hemorrhage. Then next we have epidural or subdural hematoma. Right, epidural or subdural hematoma. So these are all the etiologies which will cause the hemorrhagic stroke. Now you need to know, in case of the cerebrovascular accidents, what is the most common cause now? Is it a hemorrhagic stroke, or is it a thrombotic stroke, or is it an embolic stroke? The most common cause of cerebrovascular accident will be the embolic stroke. And what is the most common source for the emboli? The most common source for emboli will be of cardiac origin. Right, the most common source of systemic embolism is from the cardiac origin, that is intracardiac thrombi. Now, what are the causes of intracardiac thrombi? These intracardiac thrombi, they are formed as a result of they are formed as a result of atrial fibrillation. They are formed as a result of ST elevation MI causing left ventricular dysfunction. Next, and this left ventricular dysfunction, it should be severe left ventricular dysfunction, then followed by that the heart failure, okay, with reduced ejection fraction, right, heart failure with reduced ejection fraction. So these are the causes for the formation of intracardiac thrombi, and this intracardiac thrombi will shower an emboli resulting in the embolic stroke. Now followed by that, so these are the causes for, most common cause for cerebrovascular accident, that is embolism. And I said you the other etiologies which will cause cerebrovascular accident is hemorrhagic stroke. Most common embolism, followed by that thrombosis, followed by that you have the hemorrhagic stroke. Now hemorrhagic stroke also, what did I tell you? You have intracerebral hemorrhage, that is intraparenchymal hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, extradural hemorrhage. Any of these three sites, if there is hemorrhage, there can be development of neurological deficits. But what is the most common cause of intracranial hemorrhage causing cerebrovascular accident? If the question is like that, then most common cause of intracranial hemorrhage causing cerebrovascular accident will be intracerebral hemorrhage. And what is the most common cause of intracerebral hemorrhage? That will be hypertension. Right? Most common cause of intracerebral hemorrhage will be hypertension. Then what are the other common causes of the intracranial hemorrhage? The other common causes include ruptured berry aneurysm, number 2, ruptured AV malformation, number 3, cavernous angioma, number 4, trauma including post-traumatic apoplexy. Right, next common etiology is trauma. So these are the other common causes of the intracranial hemorrhage. The most common cause of intracerebral hemorrhage will be hypertension. The other causes, these are listed below. And if hypertension is the most common cause of intracerebral hemorrhage, you need to know what is the most common site for hypertensive hemorrhage. The most common site of hypertensive hemorrhage are the putamen. Right, that will be putamen. Okay, so putamen, it is a part of your basal ganglia, and okay, part of the basal ganglia. And what are the other sites of the hypertensive hemorrhage? The hypertensive hemorrhage can occur within the thalamus, can also occur within the deep cerebellum, can also occur within the pons. So these are the other sites where you have the hypertensive hemorrhage, but the most common site will be within the putamen, right? Now, after having said this, you see some of the questions. Most common cause of cerebrovascular accident is embolism, arteriovenous malformation, venous thrombosis, hemorrhage. So the most common cause will be embolism. Then you see the next question. Most common cause of the embolic stroke. Intracardiac thrombi. Second option, particulate matter from intravenous drug injections. Protein C deficiency. Antiphospholipid antibody syndrome. It is your intracardiac thrombi that will be the most common cause for the embolic stroke. Now, in this particular ischemic strokes, you need to remember one terminology called as watershed infarcts. See, the another name of this watershed infarct, it is also known as border zone infarcts. Right, it is also known as the border zone infarcts. And these watershed infarcts, they develop from relative hypoperfusion in the most distal arterial territory, right? So it is due to hypoperfusion of or hypoperfusion in the most distal arterial territory. Right? So that will be your watershed infarct. And in these patients with this watershed infarcts, they can produce bilateral symptoms. Right? They can produce bilateral symptoms. Okay? And these watershed infarcts frequently they occur perioperatively or in situations of prolonged hypotension. So they occur perioperatively because perioperatively there is volume loss of the blood, right? Or this watershed infarct can occur in situations of prolonged hypotension. Right? So these are the causes for the watershed infarcts. Then, so what is this? It is a border zone infarct. That means it is the infarct between the territories. So you have anterior cerebral artery, middle cerebral artery and posterior cerebral artery. So in between the anterior and middle cerebral artery, whatever the territory is there, that borderline area between anterior cerebral artery and middle cerebral artery, that area is nothing but your border zone infarcts. And again, between the middle cerebral artery and as well as the posterior cerebral artery, that particular area, whatever is there, it is nothing but your border zone infarcts. Then you need to know about what is called a Binswanger disease. Binswanger disease, the other name of it is subcortical arteriosclerotic encephalopathy. Subcortical arteriosclerotic encephalopathy. So that is about your, another name of the Binswanger disease, subcortical arteriosclerotic encephalopathy. So here, what the individual will have is, the individual will have multifocal small infarcts. Right? Multifocal small infarcts. Right? So this multifocal small infarcts will result in slowly progressive neurological disorders. Okay, will result in slowly progressive right, will result in slowly progressive neurological disease. And that particular slowly progressive neurological disease is the one which will cause multi-infarct dementia. Right, will result in multi-infarct dementia. So that is what is your Binswanger disease. So Binswanger disease, another name of it is subcortical arteriosclerotic encephalopathy. So it is due to arteriosclerosis, and in these patients there is multifocal small infarcts or ischemia, and that will result in slowly progressive neurological disorders, and that neurological disorder will be in the form of multi-infarct dementia, right? That is what is your Binswanger disease. So it is again a form of ischemic stroke. Now you see a question here, what is the most common cause of intracranial hemorrhage? Just now we have discussed subarachnoid hemorrhage, intracerebral hemorrhage, subdural hemorrhage, extradural hemorrhage. The answer is the intracerebral hemorrhage. And if you see the next question, the commonest cause of intracerebral hemorrhage, thrombocytopenia, diabetes, hypertension, berry aneurysm. What is the answer? It is the hypertension that would be the common cause for the intracerebral hemorrhage. Then, which of the following is the most common location of the hypertensive hemorrhage? Pons, thalamus, putamen, subcortical white matter, right? So the site of hemorrhage will be the putamen, right? Putamen will be the most common location of the hypertensive hemorrhage. Next, most common cause of subarachnoid hemorrhage: hypertension, rupture of berry aneurysm, intracranial tumors, arteriovenous malformations. So the most common cause of subarachnoid hemorrhage is the rupture of the berry aneurysms, right? It is a rupture of the berry aneurysms. Now actually the most common cause will be, so if you take the etiology, right, if you take the etiology of subarachnoid hemorrhage, the most common cause of subarachnoid hemorrhage will be head trauma. But in our options which has been given to us, head trauma is not there in the options. That is the reason why we have gone to the second, that is rupture of berry aneurysms, right? The second most common cause will be rupture of berry aneurysms, right? And what are these berry aneurysms? Berry aneurysms are the aneurysms originating from circle of Willis, right? Berry aneurysms are aneurysms originating from circle of Willis. That is called the berry aneurysm. And you need to know one important terminology called mycotic aneurysm. See, mycotic aneurysm, it is not the aneurysm secondary to fungal infections. Let me tell you, even in case of mycotic aneurysm, there is ballooning out of the vessel. That means there is dilatation of the vessel. So here the mycotic aneurysm, it is caused by a septic embolus. Right, it is caused by the septic embolus. So this embolus, it contains the infectious bacteria, and the bacteria which is present within the embolus will enter into the vessel wall, and this will cause the weakening of the wall of the vessel. So this will cause this will cause the weakening of the wall of the vessel, right? So that is what is your mycotic aneurysm, which is secondary to the septic embolus, right? And subarachnoid hemorrhage, it is secondary to rupture of berry aneurysm. And you need to know what is the, so most common cause of subarachnoid hemorrhage, here the answer is rupture of berry aneurysm, because we don't have the head trauma in the options. Now, what is the most common site of berry aneurysms? junction of anterior cerebral artery with anterior communicating artery, first option. Second option, junction of posterior communicating artery with internal carotid artery. Third option, bifurcation of middle cerebral artery. Fourth option, vertebral artery. So, the most common site in the descending order of the frequency, if you see where you have the berry aneurysms, the most common site is at the junction of anterior communicating artery right, at the junction of anterior communicating artery with anterior cerebral artery, right, junction of anterior communicating artery with anterior cerebral artery. That is the most common site of the berry aneurysm. Now, the second most common site for the berry aneurysm will be at the origin of posterior communicating artery from the stem of the internal carotid artery. That is at the origin of posterior communicating artery from the internal carotid artery. That is the second most common site where you have the berry aneurysms. Then the third most common site is we have middle cerebral artery. Middle cerebral artery, it will divide into the superficial branch and as well as a deep branch. So, exactly at the major bifurcation of middle cerebral artery, so at the first major bifurcation of middle cerebral artery, that is the third most common site where you have the presence of berry aneurysms. Next, and the other site is, the fourth common site is at the bifurcation of internal carotid artery into middle and anterior cerebral artery, right, that is at the bifurcation of internal carotid artery into middle and anterior cerebral arteries. Okay, so that is another site. So internal carotid artery, the terminal branches are ACA and MCA. Exactly at that bifurcation you can have this berry aneurysm, and the least most common site where you have the berry aneurysm is at the vertebrobasilar bifurcation. Right, at the vertebrobasilar bifurcation. So these are the common sites in the descending order of the frequency of where you have the berry aneurysm. The most common site will be at the junction of anterior communicating artery from the anterior cerebral artery. Next, followed by that, this berry aneurysms. So what is the answer in this question now? Most common site of berry aneurysm will be junction of anterior communicating artery with anterior cerebral artery. Now, if you take this berry aneurysm, where exactly the defect lies? First option, degeneration of internal elastic lamina. Second option, deposition of mucoid material in the media. Third option, defect in the muscular layer. Fourth option, disturbance in the vessel wall. So, berry aneurysms, let me tell you, the defect lies in the deposition of mucoid material in the media. Right, deposition of mucoid material in the media is the one which will cause weakening of the vessel, and that will cause the berry aneurysm. Now, followed by that, you see another question. Cerebral ischemia occurs when cerebral blood flow is less than 10 milligrams per 100 grams per minute, 10 ml per 100 grams per minute, 20, 40, 50. So, what should be the cerebral blood flow to have the development of cerebral ischemia? Now, we have a concept called as cerebral autoregulation during the stroke. See, cerebral autoregulation is impaired during some diseases including ischemic stroke. Now, what is this cerebral autoregulation? Let me explain you. See, whenever the cerebral perfusion pressure falls, right, when cerebral perfusion pressure, when it falls, what happens is the cerebral blood vessels, they dilate. Right, cerebral blood vessels, they dilate. And once the cerebral blood vessels dilate, there will be increased blood flow. Right, whenever the cerebral blood vessels dilate, there will be increased cerebral blood flow. Now, this increased blood flow should be sufficient to fulfill that decreased cerebral perfusion pressure. But for suppose, if that increased blood flow, if it is not fulfilling that fall in cerebral perfusion pressure, then the brain will suffer with ischemia. What is autoregulation? Whenever the cerebral perfusion pressure falls, cerebral blood vessels should dilate to increase the cerebral blood flow. But the amount of blood flow going to the brain parenchyma, if it is not sufficient due to fall in cerebral perfusion pressure, that we consider that, or then we consider that cerebral autoregulation has failed. Okay, so due to this decrease in cerebral perfusion pressure, right, if the fall in cerebral perfusion pressure, if it is beyond right, if it is beyond the ability of the brain to compensate, right, if it is beyond the ability of the brain to compensate, this will result in decreased cerebral blood flow. Right, this will result in decreased cerebral blood flow, resulting in the development of ischemic stroke. Now what is our question? What should be the cerebral blood flow in order to have the development of cerebral ischemia? So you see this question, when the cerebral blood flow, you see this table, when the cerebral blood flow is less than 50 ml per 100 grams per minute, at this level of cerebral blood flow, there is inhibition of protein synthesis. Right, there is inhibition of the protein synthesis. And when cerebral blood flow is around 35 ml per 100 grams per minute, then protein synthesis completely stops. Right, protein synthesis it completely stops. Okay, and the glucose utilization is increased because protein synthesis is not occurring. The cell will try to look for the alternative source of energy, that is the glucose utilization. Right, the glucose utilization is increased transiently, that means for certain period of time. And when the cerebral blood flow is less than 25 ml per 100 grams per minute, the glucose utilization also drops dramatically. Okay, so glucose utilization drops dramatically, and once the glucose utilization drops dramatically, there is onset of anaerobic glycolysis resulting in the tissue acidosis. So the glucose utilization drops and there is onset of anaerobic glycolysis. And once there is anaerobic glycolysis, that will result in lactic acidosis of the tissues. Right, so within the tissue there will be accumulation of the lactic acid resulting in lactic acidosis. And when the cerebral perfusion or when the cerebral blood flow is less than 20 ml per 100 grams per minute, that will result in the development of cerebral ischemia without infarction. Right, that will result in cerebral ischemia without infarction. Okay, so here the cerebral ischemia, it is reversible. Right, that means that ischemia, whatever is about to develop, it is reversible once the blood flow is again returned back to normal. So here the individual will develop a clinical syndrome of transient ischemic attack. Right. So here the consciousness is usually lost as the brain tissue loses the capacity to make neurotransmitter substance, because there is a tissue acidosis. The brain is unable to make the neurotransmitters, so the consciousness is lost here. But it is cerebral ischemia without infarction, whereas when the blood flow is less than or equal to 16 to 18 ml per 100 grams per minute, there will be neuronal electrical failure. Right, there will be neuronal electrical failure. So within 1 hour, that means if the perfusion is less than 16 to 18 ml per 100 grams per minute for 1 hour, then there will be development of cerebral infarction. Right, cerebral infarction will occur within 1 hour. And if the cerebral blood flow is less than or equal to 10 ml per 100 grams per minute, then in this scenario there will be cerebral infarction within several minutes. So there will be cerebral infarction within minutes. That is when the flow rate is less than 10 ml per 100 grams per minute. And when the cerebral blood flow is like 0, then the death of the brain tissue will occur. Right, death of the brain tissue will occur within 4 to 6 minutes. Right, so this will be the effect on the brain depending upon the flow rates. Right, depending upon the flow rates. So you see this question now. Cerebral ischemia occur when cerebral blood flow is less than 20 ml per 100 grams per minute. Right, so this is a flow chart, that is effect of decreased cerebral blood flow on the vital organs. So at a blood flow of less than 50, the protein synthesis will get inhibited. At a blood flow of 35, protein synthesis stops, the glucose utilization starts. 25, there is onset of anaerobic glycolysis and there is tissue acidosis. 17, there is neuronal electrical failure. 11, membrane failure, and below 10 there will be cell death. So this is the effects of decreased blood flow on the vital brain functions. Now this cerebrovascular accidents, It could be mainly due to three reasons. Either it would be hemorrhagic stroke or a thrombotic stroke and embolic stroke. And you should be able to differentiate whether it is a hemorrhagic or thrombotic or embolic without imaging study. How can you make out, how do you differentiate between these three clinically? Let me discuss. So, hemorrhagic stroke, most of the time if you take the time of onset of the stroke, it is during the activity. Right, at the height of that particular activity, the individual, if they develop stroke, that would be a hemorrhagic stroke. And thrombotic stroke, usually it can occur within the sleep. Embolic stroke, let me tell you, at any point of time, right, at any time there can be development of embolic stroke. And how will be the progression? Hemorrhagic stroke, the progression of the neurological deficit will be over minutes to hours. Right, the progression of the neurological deficits will be over minutes to hours. And thrombotic stroke, the progression is on waking up or over hours. So usually on waking up, you will observe the presence of the neurological deficit. That will be thrombotic stroke. And embolic stroke, neurological deficits will be within seconds. So within seconds, there will be development of the neurological deficit, where in case of the embolic stroke. And you take the next important, that is transient ischemic attack. Transient ischemic attack, it is usually absent in case of the hemorrhagic stroke, but thrombotic stroke, yes, it is present, and embolic stroke, it may or may not be present. And what about the headache and as well as the vomiting? In case of the hemorrhagic stroke, the vomiting, it is recurrent vomiting will be there. Whereas in case of thrombotic stroke, the individual will have no vomiting or there can be occasional vomiting, right? Absent or occasional vomiting. The same is even in the embolic stroke. And you take the headache. Headache is very prominent in case of, right, headache is very prominent in case of the hemorrhagic stroke, whereas thrombotic stroke, the headache is mild, right, or absent, right, even if it is same even in case of the embolic stroke as well. And what about the early resolution? Early resolution in case of the hemorrhagic stroke, that is within minutes or days, it is unusual. Whereas in thrombotic stroke, it is variable, and embolic stroke, early resolution, it is possible, right, early resolution, it is possible. And what about meningeal irritation? Meningeal irritation, it is present, right, may or may not be present in case of hemorrhagic stroke, but thrombotic stroke and as well as embolic stroke, meningeal irritation is absent. And what about the carotid bruit? Carotid bruit, let me tell you, it is not seen in case of hemorrhagic stroke. But this carotid bruit, it is possible in case of the embolic stroke, and it is highly supportive, right, even in case of thrombotic stroke, there can be the carotid bruit. Then what about valvular heart disease and the atrial fibrillation? Valvular heart disease and atrial fibrillation, it is absent in case of hemorrhagic stroke, unusual in case of thrombotic stroke, and it is definitely present in case of, most of the times it is present in case of the embolic stroke. And imaging, I will discuss that separately, but based on these features, you should be able to differentiate whether the individual is having hemorrhagic, thrombotic or the embolic stroke. So this is about, the basic introduction of cerebrovascular accident, that is ischemic stroke, hemorrhagic stroke. Ischemic stroke again, embolic stroke and thrombotic stroke. Most common, embolic stroke. Most common source of emboli, that is intracardiac thrombi. What is the cause for intracardiac thrombi? Atrial fibrillation, heart failure, ST elevation MI. And hemorrhagic stroke, most common site of hemorrhagic stroke, that is intracerebral hemorrhage. Most common cause for intracerebral hemorrhage, hypertension. Most common cause of subarachnoid hemorrhage, head trauma. Second most common cause, rupture of Berry aneurysm. Most common site of Berry aneurysm, that is at the junction of anterior communicating artery with anterior cerebral artery. And this is the table which you need to know how to differentiate whether it is a hemorrhagic, thrombotic or embolic stroke. So this completes the discussion on the basic introduction of the cerebrovascular accidents. Thank you very much.